if you guys ever have a chance to read like interesting study, this one here, it talks about the, so especially for like a rotator cuff repair, so this study is actually for rotator cuff repair. I do this for, do you mind if I borrow the
Sideways.
Trying to go up.
Yes.
That's right.
Oh, you have to like shift it. We're gonna go up to where elbow is. Thank you. Perfect. Okay, so that study is looking at muscle activation, so deltoid muscle activation post rotator cuff repair. And so in that case study, it talked about like having pain right here at the anterior deltoid. So I'm going to use my left knee as an example here. But that's like the #1 spot. If you have a post-op shoulder, they're like, yeah, I have pain right there. And so it's usually like a huge knot inside their anterior deltoid. And the reason for that is because just like when we think about knees in general, you have the knee swelling that occurs that causes muscle inhibition, you have arthrogenic inhibition that occurs. And so you have decreased quad activation. After shoulder surgery, the same thing happens. You just don't really quite see it like the knee does. Like there is shoulder swelling, you have arthrogenic inhibition, and that actually like causes the rotator cuff to become like less active. And so therefore the extra-articular, the rotator cuff is technically like extra-articular, it's still part of the capsule. But the rotator cuff isn't as affected to that arthrogenic inhibition. It actually becomes more dominant for that reason. And so, I'm sorry, the deltoid is, more dominant. Thank you. And so, because the deltoid, if that's like, after any sort of surgery or insult, your body's natural reaction is to guard, and the deltoid is the one that's going to be the most active. That's why you get that knot and that pain on the anterior deltoid. So basically your entire early phase rehab for at least a post-op shoulder, is my plug for it, is going to be like try to get that anterior deltoid to relax. And then same with like a frozen shoulder, and same thing, like they might be feeling pain, like their deltoid being dominant, but regardless, like these exercises are good just to totally relax all muscles of the shoulder. And so that's kind of we like lump that in to all of them together. And so that paper really talked about like table slides, pendulums, pulleys, dowel exercises, and it basically stratified the highest activation to lowest activation. The lowest activation at deltoid is the table slide, next being the pendulum. So those two are consistently in my practice. I don't utilize, as you can see on there. Although there's like low load, long duration, but like that's lower down. That's like it's gonna take it's not my first go-tos. And so I actually stay away from like dowel flexion, and then that kind of goes back to like our like what we're driving home is that you have to get rotation before flexion motions. So I stay away from that. It's also because the evidence talks about that being one of the highest for deltoid activation. And then like pulleys, I do utilize pulleys, but I definitely I use it in tandem with the table walkaways. Because I find that it is getting a little bit of shoulder flexion range of motion, but really what I'm trying to train is it is a linear motion, but what I'm trying to train is the brain just being okay with just the shoulder moving while the arm stays relaxed. And that's kind of, again, what this is doing. It's just a different construct of what we're doing here. So the way I teach the table slide is because it's the least amount of deltoid activation, it has to be completely relaxed. And so I use and it can't, I put and it's kind of extravagant setup here, but I put the piece of wood on here because it needs to be frictionless. Because if there's friction involved here, I'm gonna have to use my arm to move that forward, and you're gonna use anterior deltoid. And so if you get as frictionless as possible, you're gonna have the least amount of deltoid activation.
One thing I've seen is 2 garbage bags. Put one down and put your hand on the other.
Yes.
And then you have no.
Yes, you can do that too. The problem with that is these tables are soft, And so you will get a little bit of resistance because of this, like the softness of the table. But that works great at home. That's what I use at home. So either I use like a pillowcase at home on the like counter or kitchen counter or something like that. Unfortunately, these tables are like just a little soft. Where it depends on some of them are a little firm where you can get away with that. So essentially, what you're gonna do is elbow stays on the actual table the entire time. Elbow does not come off table. I'm gonna move the arm slightly forward such that it's in front of my body, and I'm moving my body to be next to the table. I'm causing, like, remember how I talked about we're using the long lever like to compress the shoulder and pack it back. You're staying behind your elbow to when you lean forward, you're pushing your arm forward by staying behind your elbow joint. So you're pushing your arm forward with your body, and then you're going to go until you like, as much as you're like pain free. Like if that's here, it's great. If it's here, it's great. And then what you're gonna do is you're going to sit on up, but see how my arm stays there? I'm basically taking the slack out of the arm and I'm dragging it on back. And then I'm coming back up to center. And sometimes what happens is if it gets behind you and you move forward, they're gonna do something like that. Move it forward, get it in front of them, sit next to it, push the, like use your chest, push it forward, take up the slack, and like I've gotten good success by using the verbiage like drag your arm back. Because that type of verbiage there, like you're gonna get that component of the brain not guarding with any arm motion. And so I understand, like, you know, it's like, oh wait, we talked about like rotation before linear motion. Like the point of this is not like to gain range of motion, it's to increase muscle relaxation when you actually move the arm. And so we're just trying to train the brain that it's okay to move this arm right now, even though I had surgery. Yes.
Why wouldn't you just do like a passive shoulder flexion by just taking a step back, like having your
Yeah, that's the table walk away one. That's a great exercise.
Okay.
Yeah. The thing.
I found myself like, this one works for some patients and for some it's like, ugh.
Yeah, no, I agree, and that's why like I wanted to talk about like more of like the mechanics behind it. I think really matter of the elbow. If you don't have the elbow down, you're raising the arm up. And so that's gonna set you up for the best success. And then the table walkaway one is great. The problem with the table walkaway is it's actually like a reverse, like for the brain component when you move later for motor control. Like it's not really natural like kinematics of like when you raise your arm up. Like, yeah. So I just have found like that it's more of a closed chain way of getting shoulder flexion versus this is a little bit more of like a open chain way of sliding it back and forth. So it's a great exercise. Yeah, it's not part of the study, which I think it should be though. All right, and then pendulum. So does anyone use a weight for pendulums? Sometimes. When do you start using weights? Right away? Sometimes. Yeah.
Depends.
I use it almost all the time, right away. And the reason for that is because it gives the sensory feedback, like the body that sensory feedback of letting the arm just hang. And so I will first have them start hanging down and just let them relax. And the amount of times that you'll see this occur where they're not relaxing, so I don't even start any motion until they can prove to me that they can relax that arm down, and I come over and I tap it and I let that thing hang and I let it stop. And so once they can prove that to me, then I will move into motions. And the way I move into motions is I go linear before circular motions for this one, because it's just much easier to like rock the body forward and backward than like around side to side. So I usually start forward, backward, then I go side to side. The way I do that is I actually go through pulses and not continuous motion. So I will pulse forward, backward, and I'll stop. The stopping motion is going to allow the arm to dangle. So forward, backward, stop. And I want them to fully stop before I repeat that. If you have them go forward, backwards, you actually don't know whether they're staying relaxed. Like they could still be somewhat active as they do it. So by having them do the pulses, you actually totally know that they're stopping. There's a good research study that talks about pendulums and gapping formations that occur after rotator cuff repair, and they found that doing passive, so completely relaxed, small amplitude pendulums is safer, is the safest, which I think we can all agree upon because it's passive. But the larger amplitude passive pendulums is actually more advantageous than doing a small active pendulum for causing rotator cuff gapping formations, and that's because of the actual amplitude of the rotator cuff having to hang on. It causes more of force to have to work through the sutures. And so for those for gapping formations, just to we're all clear on this, as you have the rotator cuff that's here, they do usually a mattress type of suture that occurs. And so you want that type of if my rotator cuff's here and they suture down, you want a really tight sort of suture in there. And the more that you the repetitive motion is what causes gapping formation. So imagine I have my shirt here in the seam and I pull that seam across and you start seeing the little dots that are from where the seam go through. That's what the gapping formations occur, and that it has a higher risk of not having a positive outcome or a re-tear effect.
You're saying that can happen with the large.
A large passive so in this they did it with circles. So large passive ones will is more advantageous than small active ones.
That's confusing how you're saying. So you say it's more advantageous?
Sorry.
So
Thank you.
it causes more potential for disruption of the
Yes.
healing of the.
Yes.
That's what you're saying. Okay.
Active ones.
Yes. The active ones do.
The
The active ones don't.
Don't. You're saying
Yes.
large passive.
A large passive is worse.
Is
than,
not. Yeah.
than
It's
small
more
active.
dangerous.
Yes.
Okay.
Thank you.
Yeah.
Which is thank you.
So how do you figure it out with, inhibiting the deltoid? Do you worry about that at all? Because
Yep.
you're holding a weight, so there is some stability occurring here, some tension occurring here. But you have a lightweight, so it's better than nothing, but still, I wouldn't wanna put something here either. I was thinking of cuff weight.
Yeah. So I have used the cuff weight before. The cuff weight's kind of nice because they don't have to feel like they're gripping, because gripping is associated with rotator cuff activation.
Yeah.
But I feel that the way of just starting in that sequential fashion where you have the arm just hang down, and then hitting, basically you doing that has been very successful in terms of getting the deltoid to relax. If I bring up that study about pendulums because you're gonna start seeing people do larger amplitudes within even the linear motions, and I want to bring that up. That's why I was bringing this up. Is I want you just keep it nice and small.
Well, it's also interesting because
Yeah.
you could do passive. If you're having to slow, the body will slow down that momentum.
Mm-hmm.
But if you were doing it passively like this,
Yeah.
and you've seen these,
Yeah, the
those kind of
cradles,
things, that's probably a whole different outcome. That possibly is
It
a
could
different
be.
outcome. You know what I mean?
Yeah.
I bet they didn't study
They didn't
that.
study that one.
Yeah,
So it's hard to
it'd be
hard to
interesting,
know.
hard to know.
Yeah.
Yeah.
Yeah. It's
But
really
I could
study.
see how your body's trying to constantly slow down that momentum,
Yeah.
and it's going to activate things
Yeah.
and pull on it. So.
The cradle is interesting because so I have a this is just anecdotal because it's nothing. But knowing about the cross communication that happens with contralateral arm motion, I suspect that with the cradling of your other arm, you're getting some sort of activation of
Oh,
deltoid
that's
motion
true.
with that.
Yeah.
That's what I suspect, but I don't know.
That's true.
Yeah, I don't know. Yeah. And then table walkway. So table is gonna have to be there you go.
Yeah, I'm just gonna chime in on the pendulum conundrum, right? So, what I have found with the cuff weight is that people have some nervous, because they're not in control of their weight, they're nervous about it falling off, and so they will stay somewhat guarded. And then, when you grip, your rotator cuff reflexively engages. So I typically use what I call a prong grip, so that the hand is limp. And I hear you on like, yes, it is a small percentage of the weight of the limb, and they're usually in a sling at this time point. But it's actually an unfair ask for someone to do a pendulum when the definition of a pendulum, going back to, let's talk about physics principles just for a hot second. So the reason why a pendulum works is because the majority of the weight is at the distal end of the swinging line or whatever it is. But because your hand and your arm is like a cone, right? My upper arm weighs much more than my distal arm. So if I can't move at all, right? Or if I'm trying to get my arm to move and I try to do my pendulum and it's not moving, people are like, what the hell? It's supposed to be moving, right? And then they'll like actively move their arm as a result. But it's really just physics working against them, right? And we're like, oh no, it's with your body, it's with your body. It's like, no, you just don't, you need to have a distal load relative to the shank.
A lot of them come already, the doctor has told them to do circles.
Yeah.
I get that.
I'm
Yeah.
teaching them.
Yeah.
Yeah.
Because they get those like 2 weeks post-op, right? And so,
Or they come home with instructions before surgery.
yeah, exactly. And so, like, that's where you, like, you know, they have that type of deltoid pain, right? And so you have to relax the shoulder. Like, unfortunately, you have to break that habit of it. And I think that's where you just, like, if you break it out into those different components, it'll help, like, it'll make it seem like a new exercise for them. They're actually more receptive because they've been doing that probably the last 4 weeks. So, okay, good. All right, table walk away. So this kind of, your hands are on the table. So this is like a more of a closed chain focus. Sometimes I use like the sink, and so I can have their hold their arms, and I'm just walking away here, coming down, and then coming back up. And again for this, I'm staying pain free, arms staying completely relaxed with this one. I'm coming back, sitting back in my legs, and coming back up. And so again, the reasoning for this is just to keep the arm relaxed and train the brain that it's okay to move the arm. Like the arm's okay to move when it's relaxed. And then not on here, but I utilize the pulley system. I mentioned to Michael yesterday, your guys' pulley system's awesome. I'm trying to find a way to like make that in my clinic right now. Is because it comes right over top of you. So you're not having to fight against like going backwards. And so if you can try to get something like that, it's awesome because you can come back up and you can stay relaxed as you go back, as you bring that arm into flexion. And so I've moved away from a lot more of the pulleys just because, again, it's a hard thing to actually see whether they're completely relaxed or not. I kind of do utilize that once they've proven to me that they've got like this muscle relaxation down, and then we can start just mostly like progressing their flexion range of motion as we are improving their rotational range of motion too. Okay, and then low load, long duration holds for external rotation. So with this one particularly, thank you. Can you demonstrate?
I can be.
You want to demonstrate?
Yeah.
So this is where we're gonna utilize the sorry, hold up very well. This is where you utilize the word it depends on the patient. But so let's say our patient that we had specifically was like about 10 degrees of external rotation down by side, right? And so if they're able to completely relax, I would imagine that they're actually going to be having more after just doing those few exercises. I don't add the low load, long duration holds until they can prove to me that they can relax. Because what I'm going to do is have them hang out in this end range here. So let's say like this is where they're at. I try to get that hand relaxed, and I'll literally hold them here and let them relax. And as tension goes, I'm gonna just let their hand slowly work its way down. And this is a painful sake, like it's painful to like have them watch it sit there for 5 minutes, but yeah, I'll literally have them sit there on the table for 5 minutes. And I'm letting the arm just like let gravity do its thing. So it's kind of similar, again, I go back to the knee on low load, long duration holds for a knee extension, and putting them on like a heel prop and just letting gravity do its work. It's the same thing for the shoulder for rotation at this time point. I don't utilize a dowel until like I feel that they can totally relax into this arm. So to appreciate the fact that they have some stiffness that occurs. But what you're gonna feel is when they first start doing this, is that's when you start seeing that little like bicep reflex occur, or they'll have like this little like jolting motion when you get to their end range. So what I'll do with this is I'll go right to when I see the first bicep click and I'll hold, and I'll hang out there for a little bit until I kind of feel the arm kind of give me a little bit more of like relaxation in my hand. And then I'll go again, might feel a bicep there again, and I'll continue to wait. And then, okay, so that's for externalization. Then I will add a dowel later on, but this is like beyond, this phase. First, I'm already jumping ahead, but we'll talk about the dowel later on when we're talking about rotation isometrics. But the last one is shoulder flexion, low elongation holds. So I'm going to stand on up. We're going to go over to, so this is something that I'm going to put the caveat for. It works decently well for the guarded, like what feels like a guarded adhesive capsulitis. So this is like that shoulder that patient had like maybe a rotator cuff tear that turned into them guarding, that turned into like what's that, like an adhesive capsulitis. So what I call it is like adhesive capsulitis secondary to a rotator cuff tear or a shoulder impingement. Those types. What I'll do is it's more of a distraction moment, and so rather than a rotational moment, so I'll have them either, if you have a like ladder available at the clinic, or I usually again use a sink. So if I'm going to use a sink height, I'm going to hold on. I'm going to use my left arm so you guys can see. Hold on here, and then I'm going to actually pull back so I get a little distraction moment, and then I will sit into that. The distraction component of that again allows the arm to relax and you to gain a little bit more flexion range of motion. But again, I'm not doing this in sole like isolation. I'm more promoting again more of that externalization and then going right into this right after. So in terms of like my treatment like sequence for this, it is after I do the externalization. And the reason for that is because once you gain like motion in externalization, I'm going to try to utilize that to maintain my flexion range of motion, which is what you need for functional activities. Yeah. All right. Any questions on this?
What are the?
Sorry, part of the table walkway.
Yes.
Do you find like doing it with thumbs pointing up to just kind of incorporate more of that external rotation like with that?
Yeah.
Be a little more beneficial than having it with palms down?
So I have later, but that's when I'm trying to again promote more range of motion. The purpose of this one is purely muscle relaxation. Yes, but yes, I do like that is a progression.
What is the dosage of these, and are you doing all of them, are you doing some of them, and how do you structure that?
Great question. So my go-tos are the first three right there: diaphragmatic breathing, table slides, and pendulums. My pendulums, I am like same with table slides. The dose response for that, and this is kind of all for like the entire first phase of rehab, is basically until they get bored.
Until what?
They get bored, which is like a minute or two.
Okay.
Like, cause I want them to like intuitively like actually focus on what they're doing. Cause if they're not focused on what they're doing, it's just becoming like, oh, I need to get 10 done. Those 10 are probably not gonna be done right. And so I actually like challenge them and purposely say, yeah, like if you get 2 done, that's great. That's better than doing 10 wrong ones. Because the point of this is purely muscle relaxation, and if you're promoting any sort of activation, then it's not working towards our goal. So I purposely don't actually like, that's my dose response for that. Yeah.
Multiple times a day, that's frequency wise?
Yes, I try like at least 5 times a day. Yeah, like so my frequency is more often because it's like I'm much more lenient on like
The dosage.
the dosing aspect, and like so like if they're feeling like pretty refreshed mentally, and they're like, oh yeah, shoot, I can hold a pendulum right now for a couple minutes, fine. Yeah. Because again, I'm trying to promote that neurological system just to relax.
For the external rotation one, were you like supporting their arm?
Yeah.
And if so, like how would you have them do it at home if you would like?
Yeah, so that one again, I'm not giving that until they can fully relax, and they usually like they can hang out in that position and they're gonna relax into that position as they go along. But
Once they
when I'm first like teaching them it, my hand's there so that way they know it's safe. And then as I'm like once they are able to hold it there without my hand, that's when I give it as a home exercise program. Yeah, good question.
So again, my age, so I do some soft tissue to help
Yes.
with the relaxation, and then some oscillations, do that as well, besides these exercises?
So I definitely do soft tissue to the anterior deltoid. In terms of oscillations, just kind of like rocking back and forth, is that what you're like with the arm?
More like, really like grade 1 moves.
Oh, grade 1 moves. Yeah. So I do utilize some mobilizations. I tend to want to decrease a little bit of stimulus in the joint, and so like I tend to try to stick to this hands-off approach first because I'm not with them at home. Yeah. With this, especially with like the effect of manual therapy, I'm a big proponent of it. But with the effect being like about an hour of relief, like if I can do that to help promote this and get them to do it on day one, then yes, I'm all for it. But I typically like I'm gonna try this first. If I can't see improvements, then yes, I definitely do that. Yeah, I do grade 1s and 2s.
Yeah, I was just gonna say, with these exercises, what are the biggest mistakes that you see? Are there any?
Yeah. The table slide one of like they're like you're not moving their arm in front of their body. They'll move it. They'll keep it to the side and they'll do that like this little chicken wing thing. Yeah, I will say like that's probably the biggest mistake I see with the table slides because it's actually something it's a hard thing to teach. But I spend like I'll spend 15 minutes teaching that one exercise because of how powerful it is when it's done right. And then the pendulum, once they're into the pulses, I see that they're starting the next pulse cycle before their arm's completely relaxed. And so that's another mistake I see.
And then with the pendulum, are you increasing the weight later on? And I just usually kept it like a 2-pounder.
Yeah, I usually just stay at like a 2 or 3. Again,
Increasing the weight.
yeah, I'm not really increasing the weight. It's a relatively safe weight, and then also, I also don't want them to like if I increase the weight and I'm trying to keep them on, especially rotator cuff repair, I'm trying to keep them from lifting anything heavier than 5 pounds or so. If you start putting a heavier weight, they can think it's like acceptable to like carry more weight. So I'm trying to make sure that doesn't happen. Yeah, good question. Cool. Yeah.
Do you incorporate any like neurodynamics in like early post-op where you're moving the wrist, maybe you're moving their neck? And
Yeah. Absolutely doing like elbow, I'm mostly doing like elbow cars, which kind of is an actual nerve like mobilizer, and then I'll do wrist, neck. Yes, absolutely. Cool. All right, you guys want to try a couple of these? Like, let's pick ones that you want to. Like, I would say like if you haven't tried the pendulum with the weights, that way you guys can feel how that feels. Let's do pendulums with the weight.